in the last class, we had some drugs which would affect our gastric acid secretions. So today I will be beginning with the topic that is anti-diarrheal drugs. So anti-diarrheal drugs, they act on much of the same receptors, okay, similar to our antacids. So diarrhea, I think most of them have experienced, and there is no person who has not experienced this disease. Okay, anyone clearly not experienced this disease? Yes. So what agents we prefer? What agents we prefer? What drugs you are taking till now? Antibiotics, only symptomatic treatment, ORS. So I think most of you know the commonly used drugs. Today we will just try to understand the pharmacology of what we knew till now. What causes diarrhea? So when we can call it as diarrhea? So diarrhea, when we can call it passing more than once per day, passing 3 times per day. Okay, so it should be more than 3 times. Okay, frequency and the consistency should be watery or frothy. It may be like that in some cases. Okay, so it is too rapid and too much of fluids. So diarrhea is the abnormal increase in the frequency and liquidity of the stools. So diarrhea, there are so many types of this, and we need to treat it based on the cause we have there. Okay, so symptomatic treatment may not be appropriate for all the conditions, but these treatments may help you for immediate, but for complete cure you need to know the reasons. So osmotic diarrhea, it may be due to lactase deficiency. Secretory type of diarrhea where too much water is supposed to be there. You can get in cholera, E. coli. Okay, so in cholera what they get as rice water like stools, and deranged intestinal motility, that may be in cases of thyrotoxicosis, altered mucosal morphology in viral gastroenteritis. So allergic diarrhea, maybe food allergy, food poisoning, all these things can be there. Drug-induced diarrhea, that is more important because we tend to use the drugs for some purpose and the patient lands up with diarrhea. What are the common drugs which we know which can cause diarrhea? Antibiotics, ampicillin, amoxicillin. There are so many drugs. Okay, the prominent ones are the antacids can sometimes lead to this problem, and also our penicillin group of antibiotics which are given orally. So I think you all remember the picture. Okay, so we have discussed the same things when we were discussing about gastric antipeptic ulcer drugs. So here we are using some drugs which are having the action at the same receptor. For example, we use this lochromide, Racecadotril, which are opioid agonists without central nervous system penetration. They tend to act on the preganglionic fibers of the acetylcholine, okay, and they have the tendency to close the sphincters. So, and we also use here somatostatin analogs. So, we got to know in the previous class that somatostatin is a universal inhibitor. Okay, what are the hormones it can inhibit? Most of the hormone. Okay, so once it is universal inhibitory, here we told that these cells, they can, what they can do, these cells, they can find the HCl concentration, H plus ion concentration from the luminal side, and once the H plus ion concentration is more, they can get activated and can release the somatostatin, which can go and block the gastric release. So here we can artificially use the somatostatin analog, okay, opioid, where they can block the action, gastric release can be inhibited, motility can be inhibited. So our drugs are acting on this acetylcholine receptors and also on this somatostatin receptors. With this background, we will go to the drugs. So antidiarrheal agents, we have anti-motility, antisecretory drugs. So acetylcholine receptors, we spoke on. That means this preganglion was inhibited by opioid agonist, but acetylcholine, you know, it is also helping in increasing the gastric acid secretion. So we can use this atropine analogs. Okay, we were also using that. Here also we can use that. Opioid agonist, loperamide, diphenhydramide, diphenhydramine, and Racecadotril. Anticholinergic drugs, we have pyrazinamide and dicyclopamide, which are prominently used for their antispasmodic action. We have this alpha 2 adrenergic receptor agonist, clonidine, somatostatin analog, that is opioid, absorbents, drugs like pavulin, pectin, bismuth salicylate, and lactose. In case of lactose intolerance, we saw there in the previous slide what are the reasons for this. Probiotics, yes, lactobacillus courageous, these are commonly used in pediatrics and most sold for purpose of controlling the diarrhea. So loperamide, it is the opioid agonist which cannot cross this CN. Okay, so we know that what opioids can cause to our central nervous system. So what they can cause, what are the side effects of opioids? First thing is, there can be hallucinations, there can be grandeur, okay, the person feels dissociated from the surroundings, and they are they habit forming opioids? Yes, they are habit forming. What happens to the pupillary size? Constriction of the pupil will be there. Yes, what else can occur? And the peripheral action of this drug is opioids is constipation. So we need only this peripheral action. So we can now synthesize or do such a drugs where it will not cross this CNS and act on only peripheral issues. So such is our drugs, this loperamide and Racecadotril. What it does? So commonly used opioids, they act on this peripheral mu receptors, okay, and they are more potent than morphine in this effect. Okay, so we use codeine, which is anti-tissue and more action on this anti-tissue work than the analgesic work. Similarly, we have this loperamide, which is having more concentrated effect than the regular morphine. So these are specific to these peripheral receptors, so that their concentration is attained more on these peripheral receptors. Naturally, their action will be good at the receptors. So more potent than morphine as an antidiarrheal agent. What it does, it increases the small intestine to secret transit time. So the transit time is decreased by inhibition of the presynaptic cholinergic nerves in the submucous and monitory plexus. So once this step is inhibited, there is you can also think about this decrease in the acid secretion also, and once the transit time has decreased, the patient feels comfortable. What happens in this regular diarrheal cases? There can be increase in the cyclic AMP levels, increase in the motility. Okay, that thing will cause spasms, and that can also be prevented with this loperamide. And the negative point is like if it is an infected diarrhea, maybe bacterial or viral, what will happen? This drug also has the property of closing the sphincters. Okay, so once these sphincters are closed, but there is excess of secretory thing which is going on, what can happen? The spasms can increase. Okay, so this is one of the things that we need to remember. So what we can do, how we have to go with this? What we can do, we can go for the antibiotics initially, or this probiotics, okay, probiotics, antisecretory, antimotility, the other drugs which are mild in action that can be given initially so that the infective work is prevented first, then we can go for the loperamide. So what happens when the patient thinks of treating himself? He will go to the medical shop, he will take this loperamide first. What happens? First he will be satisfied, but later what happens? The spasms goes on increasing because the actual cause is not treated and the patient feels okay, something is not good, already 2 days over, now it's time to meet the doctor. So intestinal motility, it is decreased with the help of this mu receptors. Okay. Then our intestinal secretions, delta, both mu and delta both decrease the intestinal absorption. So we can increase the sphincter from that's what I was telling. Antisecretory activity is also seen against this chlorotoxin and some form of E. coli toxin. Half-life here is long. Okay, so almost 11 hours, that means twice daily dosage is enough. 4 milligram initially is given, that means usually the tablet or the capsule it will be in the 2 milligram dosage, 2 tablets first day, then go for the 2 milligram up to 6 milligram. And this drug, as it can directly act on these sphincters, it is avoided in the children below 2 years. Okay, better to avoid it below 5 years. So Racecadotril, it's a newer one belonging to the same class of opioids, but it has some specific advantages. So it is a dipeptide. Racecadotril, it blocks the enzyme N-cathalinase. So N-cathalins are the intestinal secreted opioid agents, endogenous agents that is inhibited. Their metabolism is inhibited. Once their metabolism is inhibited, they can go and act on this mu receptors. So what are the action on these mu receptors? You saw in the previous slide. Decreasing the secretions are decreased, motility is decreased, all these actions are brought about. The positive point here is it is indirectly acting, not directly acting on this sphincters and all. So that's why what can happen, there are relatively milder agents and this can be used in children below 2 years. Okay, and it is again having the advantage as loperamide, that is, it is a peripheral. It has a peripheral action, no habit forming, no CNS side effects. All these things are there, which were good with our loperamide. So these drugs can be used orally, okay, and as loperamide, it is contraindicated. This is drug of choice in children's mouth. Bismuth subsalicylate. Yes, do you remember this drug? So we discussed it in antibiotic culture drug. Yes, this bismuth subsalicylate, it is a trivalent bismuth suspended in a mixture of magnesium, aluminum, silicate, clay. The negative point about this is it can form blackening of the tongue. That thing is there due to the bismuth. Okay, and this is acting as an astringent, protective, and adsorbent effect. So, what is astringent? Astringents are the agents which precipitate the surface protein and cover the superficial part and prevent the or protect the underlying surface, prevent the acid from going into the subcutaneous or below the layer. Okay, so it is a protective agent, astringent, and this action is exhibited here. In stomach, it combines with hydrochloric acid and salicylic acid can be released. And this salicylic acid can cause the adverse effects associated with this drug. So maybe increase in the acidity or inflammatory process, this can be seen here. So it can bind to the toxins of this what we call the E. coli. That is the added advantage here. Okay. And once salicylic acid is there, inhibition of prostaglandin synthesis, intestinal inflammation, that can be increased. Peptine, it is a purified carbohydrate and the exact mechanism is not known. It is helping in this diarrhea. It forms a viscous colloidal solution and coats the intestinal surface. So coating can help in further exposure to the toxin, which may be in the form of food poisoning or maybe toxin. And if there is GI acidity also, that can also be helpful by using this technique. Bile salts and what is bile salts, they can increase the intestinal motility and can cause diarrhea. What may be the reasons for increase in the bile salts? Yes? Excess breakdown of I'll leave this one for you yourself. So excess bile salts can be there. It may be in some pathological conditions, increased breakdown of the RBCs. Okay, so in these conditions it can lead to diarrhea. So the symptomatic treatment may not help, but by using the specific antidotes here. Okay, the bile salt binding vessels are cholestyramine, cholesterol, and cholecalciferol. So these can bind to the bile salts also and also to the drugs which can be used along with that, and they can decrease the bioavailability of the drugs which are used along with this. That is one of the specific adverse effects or decreasing the bioavailability of the drugs which are used together, that we need to take care. And side effects are flatulence, bloating, that can be there. So anti-motility, antisecretory, we are speaking about this anticholinergic drugs. Okay, the difenoxil, and it is a metabolite of this difenoxylate, and it can be used in combination with atropine. And you know atropine side effects, CNS, what it can cause, Maras hand, dry as bone, red as wheat, all the side effects are there. So these are tried as a reserve drugs when the regular drugs fail. And they can be toxic metabolome, constipation, all these things can be there. Other opioids which are used are paregoric and deodoras tincture of opium. So hyacinamide and dicyclomine. So these are used even though we are using the opioid. So as these drugs have more antispasmodic action also, we can use lopamide and also dicyclomine together along with an antibiotic. So this will be the common combination what they try. Okay, lopamide is given on the second day. First day we can think of this decreasing the pain. So what brings us the patient? It is always the pain. Okay, so you treat the loose screws, you treat the you give this antibiotics and tell them it will be this spasms will be over within 2 days, the patient will not be satisfied. He will shift over to the next doctor who will first relieve his pain. So we always should be taking care of this pain. Okay, so the spasmodic pain that can be relieved by the dicyclomine. So decrease in the bowel motility and can result in increase in the fluid absorption back into the intestinal tract, and it can prevent this cramps. So alpha-adrenergic receptor among this, that is clozapine. So in central cases also sometimes we can get this diarrhea. Okay, so in case of diarrhea, diabetes can cause this and opioid withdrawal. Okay, opioid withdrawal is more specific, where the person was addicted to this constipation causing drug, but now sudden withdrawal can cause this rebound symptoms. So it facilitates the absorption, inhibits the secretion of the fluid and electrolytes, okay, and increases the intestinal transit time. Once it increases the intestinal transit time, there can be few less frequent stool formation. So this is the drug which we are studying specifically in this topic, anti-diarrhea. Okay, so it is a somatostatin analog of opioid. The first slide we saw the picture how somatostatin acts, and now we are using a drug which is analog of this, that is opioid. It is a 14 amino acid peptide. It is released from the GIT, pancreas, the B cells, endocrine is all there. So what it can inhibit? It can inhibit most of the hormones secreted, growth hormone, insulin, gastrin, cholecystokinin, pyrrolysitramine, okay, glucagon, most of them are inhibited. So it slows by inhibiting the gastrin, it can slow the intestinal motility and inhibits the gallbladder contraction also, and it can inhibit this antipituitary hormones, stimulates the intestinal fluid, absorption is increased and secretion into the liver that is decreased. So both are helpful, inhibits the intestinal fluid secretion and inhibits the release of this GI peptides. So gastrointestinal peptides will be for just you saw the details there, and the next to that there was a fungus which was there, which was secreting the gastrin, and this gastrin secretion was associated with the intestinal peptides which were released. Okay, what this intestinal peptides used to pass over there, and this could stimulate the release of this gastrin. So direct inhibition is there, so and also indirect inhibition, that is by decreasing the release of this gastrointestinal peptides. So it can be used for some of the tumors which can cause the diarrhea, okay, carcinoma tumors, and it is used for secretory diarrheas, okay, gastrointestinal peptidomas, then carcinoids, AIDS-related diarrhea. In all these conditions, this can help. In AIDS, why do you get diarrhea? Can you get opportunistic infection there? Yes. So, and this in this case, what we cannot use this antibiotics regularly because already you will be overloaded with many tablets and pills, and this can again cause problem. So, low dose subcutaneously in patients with small bowel bacterial overgrowth, there we are using, okay, and we can use for pseudo obstruction secondary to scleroderma. It is used in micrograms. Just remember that loperamide we are using it in 2 grams. Racecadotril is having similar dosage, and this drug is used in micrograms. So 50 to 250 milligrams subcutaneously is given 3 times daily. So what other measures we regularly follow and why it is needed? Okay, you can see once the person is dehydrated and goes for a physical activity, what can happen? There will be increased breathing, sweating, there will be electrolyte disturbance, loss of fluid will be there, okay, reduced circulation, reduced nutrients, and patient will feel giddy and will faint. Okay, there can be this regular symptoms with nausea, headache, all these things can be there. So fluid and electrolyte replacement plays an important role for the treatment. So WHO ORS, it includes sodium chloride, trisodium dihydroxystrate, okay, and potassium chloride and glucose. So the ORS is good for everyone. Can we give in almost all the patients? Can it be used by a layman? Easy to use? Yes. What makes this ORS popular? And it is the drug of the century which has prevented most patients from death. Okay. You might be thinking which drug has saved more life. It is this one. Okay. So ORS, why it has become famous? One thing is easy to use, easy to prepare, layman can use it, and what are the side effects associated with it? No side effects. There is one, we will be discussing it later. Okay, so glucose 20 grams are used to be dissolved in 1 liter of clean drinking water. So it is given as a whole, 1 liter we can start suddenly. How we should give this ORS? It is given in small sips. Okay, 1 spoon, 2 spoon, 3 spoon like that. It is not to be taken together, and if it is taken together, we have the adverse effects. What adverse effects can be there? So this is a hypertonic solution or hypotonic solution. This is a hypertonic solution. So if you are taking together, already the big cells are having lack of electrolytes and lack of fluid. And if you again use the hypertonic solution, what will happen? Again there will be fluid drawing into the lumen. Okay, the cells are again deprived of the nutrients. So it is good to use it in diluted, correct concentration, and also in sips. Okay, that point we need to remember. So along with this ORS, we have something called as cereal-based ORS. Which is better, regular ORS or cereal-based ORS? Cereal-based? Why? So here is the answer. So cereal-based ORS, it decreases volume loss, shortens the duration of illness, inhibits the release of this cryptocell chloride channel to cyclic AMP. All this is good, and it can be done by the regular ORS also, but the exposure to the cyclic AMP, that cannot be prevented. That is an added advantage here. But actually the thing is the less luminal backtrack. That means just what we were discussing, that we use a hypotonic solution. Okay, so such effects it is seen with the direct glucose consumption, that is regular ORS. Now that's why what this WHO ORS they are doing, they are trying to decrease this concentration, making it less hypotonic by decreasing the glucose levels which we are using, which is reduced to 16 grams and now trial. So the digestive process, it supplies large number of glucose at the intestinal brush borders. So thus at the intestinal brush borders, if there is less chances that it can cause this backtrack or drag the fluid back from this intestinal wall to the lumen. Okay, that process is not so much in this brush borders for the transfer of the glucose and the sodium ions. So thereby this backtrack is prevented, and more number of glucoses are provided and where they are required. So moderate dehydration and acidosis, they can be corrected with between 6 hours of ORS. So coming to one more added disease here, that is inflammatory bowel disease. It can include both ulcerative colitis and Crohn's disease. You have heard of this disease as well? Yes? Yes, Mohit? So we are using here this drug therapy, dietary, lifestyle factors, all these things are there. Okay, so it is not a disease with single etiology, we have lot of etiologies. Okay, so with this etiologies, we are using both different modes of this treatment. So amino salicylates we are using sulfasalazine, mesalamine and oxalazine. What these drugs are doing? All of these are releasing this 5-ASA, that is 5-amino salicylic acid, and it acts as a topical anti-inflammatory agent. And this amino salicylic acid also has some beneficial effects by preventing the formation of this pro-inflammatory cytokines. So pro-inflammatory cytokines is a secondary effect, but primary effect is intestinal inflammation is prevented. So mesalamine, it is used along with this pH sensitive coating which reduces this 5-HT into the terminal ileum and colon where our disease is more. So corticosteroids, universal inflammatory inflammation suppressors or universal immunosuppressors. So these drugs are helpful. If your regular drugs are not helpful, you can go for this. Corticosteroids, prednisolone, they are used for acute and severe exacerbation of these diseases and patient not responding to amino-salicylic acid and foam-based formulations. If it is used along with it, you can coat this mucosa and help. And with prednisolone, we can get the response in about 2 weeks. Budesonide, again one more steroid, is used as a coated tablet for this Crohn's disease. So basically, we are using here immunosuppressive agents. So the anti-cancer immunosuppressants are cyclosporine, methotrexate, which can be used here in severe ulcerative colitis unresponsive to steroids. So TNF-alpha, you know it is a prominent inflammatory mediator. Okay, so we can use this anti-TNF-alpha agents such as adalimumab, certolizumab, and infliximab. All these agents, they can be helpful in decreasing the immunity and thereby prevent this Crohn's disease inflammation.